Okay, so hi everyone. Now I'm going to talk about the concept notes for healthcare access in the US and also the readings that I picked from the options of pharmaceutical, medical education, and racism. So, first off, of course, we're going to start with chapter 9. I picked chapter 9, and that chapter is all about healthcare access. And I have a lot of reasons for picking up this chapter, but mainly because I also recently did a project for another class that talks about comparing. I had to compare U.S. healthcare system with Canada, and also had to read a couple of other classmates from other countries, and it was a very interesting comparison, especially knowing in the U.S. that it's one of the things that we learn is that U.S. is one of the most expensive one, but unfortunately, compared to the other how they say it, industrialized nations, is not the best provider in healthcare, and also the life expectancy it is lower. But there's a lot of factors here like income, employment rates, age that significantly can impact whether someone can access to care or not, especially here in the US. Here, one of the things that we all know it makes US differently is that there is not an actual universal coverage. So we all know that the US healthcare system is complex, that we keep reading over and over throughout the chapters or anywhere that we read about US healthcare system. The first thing that they always do in the introduction, it's a complex system. So definitely understandable. There's a lot of, options, if you will, but still have a lot of huge gaps. But once again, it's not, like I said, it's not guaranteed the health care for all citizens, even though there is the Obamacare or the Affordable Care Act. There's still gaps, especially in those states that did not expand their Medicaid or any of that through that Care Act. I did know that in 2016, about 8.8% of Americans are still uninsured. When the Affordable Care Act did came in, I remember that there was like a penalty if you didn't have a health insurance. So, of course, that was lifted a couple years after. So that probably could make people just not be uninsured and just pay it out of pocket, because sometimes it is what it is, especially if you're in rural areas. So I did wanted to like write down a little bit of comparison with other countries. And like I said, I did a little bit more in depth in Canada for another class, but it's pretty much that Canada do has universal healthcare coverage. However, there is still, opportunities for improvement, if you will. It is, affordable in a way, but it doesn't mean that if you need something that is not urgent, that you're gonna wait. You're gonna have a long wait. So those are some challenges from Canada. There are of course, other countries with other completely different systems. I like how the other book talks about U.S. healthcare system as being like a patch collector, like patches from all the other systems built together as a U.S. healthcare system. I found that funny, but also kind of relevant. But once again, the barriers of this insurance is the CARE Act is not being expanded in all the states. Employers sometimes cut benefits to shift costs to employees, so it can now standardize benefits more consistently. And I do like this comparison, short, sweet, that insurance pretty much follows or isn't tied to the employment in other countries. Like here in the US, that if you are unemployed, there's a lot of uncertainty of your healthcare insurance or your healthcare in general. If you have chronic illnesses and all that, and you are insured by your employee and you lose your job, there's a lot of stress there. Versus if other countries, like once again France or Canada, the insurance doesn't have anything to do with your employment. So you will be like with or without a job, you still have health insurance. So that's a big difference from US to other countries. And of course, before the Affordable Care Act, there was a lot more people uninsured, but that kind of helped a little bit. And once again, from previous readings and even from the World Health website that we read, that the Affordable Care Act, it's kind of giving that like shift to US healthcare system to a more universal insurance or universal care. But there is some issues with difference on perspective or ideology of the current president and the president that actually brought that up. So that could potentially create some challenges and probably shifts things back away from universal insurance, or we'll see in the next years or so. But the ethnicity definitely influenced on coverage. Once again, very unfortunate, but I did mention in previous videos, like the Hispanic community, not Native Americans, African Americans, they all look less likely to have insurance. Hispanic also, mainly because right now with all of the immigration and citizenship challenges that they're facing, they are just scared of even seeking for health. Full-time workers are most likely to be covered. A lot of jobs definitely get some get some benefit from covering their full-time workers as well. The effect of being uninsured, once again, it's just like decrease the preventive care, so that will bring more surprise diagnosis, if you will. People are not likely to go to the provider every year to do their annual checkup, and by the time that they hit an ER, there's a lot of things going on that it will be a lot more expensive. Universal coverage, like once again France or Canada, it is a lot more consistent with preventive services that will bring their overall health to be better. But once again, the fact that it's consistent and is accessible doesn't mean it's going to happen right away. So it's just a matter of planning and making sure that you plan ahead, because a lot of times, if it's not an emergency, that it's going to be a lot longer for you to get to a provider or have the treatment you need. And then overall healthcare access in the US, it is once again very complex. There's income involved, there's employment involved, age, race, policy. We know that like Medicaid, Medicare, disabilities, if you're a woman pregnant or a child, or you're a mother of children, or there's a lot of things that are involved in like if you qualified or not. So that's what makes it so complex. And it's an information that keeps repeating itself. I always throw like a little bit of a personal experience, and in my case is that I am through that marketplace experience. Like I do have an insurance through that marketplace, and even though it is more accessible for the insurance, like I do have an insurance, there are providers that take that insurance, but sometimes, like in my case, that I do have a chronic illness that I need certain specialties and certain treatments, it is very challenging to seek that kind of help. Like for preventive, 100% covered. For basic stuff, yes. However, chronic illnesses, people with disabilities, it is still a huge challenge and a huge gap, because first of all, yes, you have an insurance, but no one wants to take it, and if they take it, it's like still long time waiting. So it's kind of the same thing as Canada. That's like kind of a little bit of that kind of relationship that I could tell, that if it's here in the US and it's like that, I could wait for months for a procedure or a specialist. I could not imagine having universal healthcare and every single person trying to get to that one provider or so. So that's kind of a good way to see how marketplace kind of maybe relates a little bit to the universal insurance or universal coverage. But that's a point that I have. And from the readings that I picked, on the medical education, I took the Burnout Among U.S. Medical Students, Residents, Early Career Physicians relative to the general population. Medical training, it is stressful. Once again, I've worked in hospitals and I've seen it. I've experienced, I as a pre-med student for a while, and being volunteer and all that, you can see that they are very stressed. And you don't have to be, it is pretty obvious. It is good that they're trying to put some importance to it and making research and kind of addressing that research to make that a little bit less stressful. But in my opinion, I also think that this education or this like experience in like the burning out and feeling like fatigue throughout your training also help them set those boundaries before even practicing or in the early stage of practicing doctor, right? Because we all know that being a physician, being a provider, it's a very stressful job overall. And you do want to help every single person that needs your help. However, that's not humanly possible. So yes, we do need to understand, or we do need to take care of our medical students and our medical residents and all that. But it's also like, this is in my opinion, like reading through this article and like remembering on my experience, this is also helpful for them in that like psychological aspect of setting those boundaries, that even though they want to help every single person that they can come across, is not humanly possible. So finding that point that you're like, okay, this is it, like this, like, is start to take care of ourselves. It is also a learning part of the medical education. And definitely social workers, like we said before, making policies and guidelines for them to not be like burn out to a point that it will affect their physical health is definitely definitely needed. Mental health is definitely needed. I do believe that they are receiving the support that they need now, because in the research of medical schools and even seeing the residency programs in the hospitals, they are having a lot of more support throughout their training. So that's very good to see. And we need more research like this to kind of see what is actually helping them and what is actually working, and where there's opportunities to do better, right? On the racism, I took the private equities transformation of American medicine implications for healthy equity concept notes, and so on. I did take a couple of notes. I did focus more on like the consequence of for health equity is definitely the access, rural, low income, older population, marginalized population, and so on. Affordability, upcoding, surprise billing, cost inflation, increase out of pocket expenses. Those are definitely affected, and can be improved with health equity, as well as the quality, staff cuts, all of that, physician service and all that. And then patient outcomes, I put evidence shows. So there's an evidence shows increased mortality, worse outcomes after private equity acquisitions, and that's very, very scary. So that one I kind of went through it a little bit faster. I didn't want to take too long. But then the last key, well, the I put on the end, the big takeaway of this, like, private equity is it provides a capital but often harms the vulnerable populations. And we go back to things that we've been seeing over and over throughout the readings, and increase the disparities on access, affordability, and quality. Effective regulation and monitoring are essential to protect the health equity, 100%. And then on pharmaceuticals, this one, I do have the experience myself as well. I am doing this weight loss treatment, and I could definitely relate to all of this that it's provided in the article. So I know it is a very expensive drug, and it's something that they say they agree to lower the prices, yet it's funny to see the payments that they are kind of negotiating for Medicare, and what I pay for it's a lot less monthly, but that's another conversation. It is definitely less than $350, but I do pay it out of pocket. My insurance did not cover it because I am not diabetic. However, my providers, my specialists that are taking care of my other chronic illnesses said, like, the best way for you to weight loss for weight loss treatment is this, and they prescribe it. So I trust my providers, so I will follow up with that. But once again, they are kind of restricting it also because a lot of people are just going crazy about it. I even saw a research recently that was posted that said that there's some like correlation with like Ozempic and other GLP-1s, that there's like higher risk for you to have osteoporosis, or like just it will affect your bones. But I feel that you just lose the appetite. So people are seeing the weight loss drug as like a miracle drug, but it's really just a drug that just like closes your appetite, and then you have to do the rest. Like, you have to make sure that you're eating your proteins, you have to make sure that you're doing all of your physical activities and so on. So a lot of people that I see are like, oh my god, no, I left the medication and I gained like 10 pounds in a week. It's like, okay, then that means that you were just taking the medication and then you were not really doing any healthier habits that will help the medication to make you do better. And once again, I saw the article, and then it really said that they're not saying that the Ozempic or the GLP-1, it's making you lose bone, but most likely a lot of, especially in the older patients, when they're taking the Ozempic, they are more likely to have a fracture, but you know, it's not that the GLP-1 is gonna make you lose bone. It's just like there is kind of a relation, and they're continuing to do more research on that. So, but going back to the article, like this article for the reading, it is going to be a struggle for low income patients, and definitely for those like commercial insurance, they have less access to it, even though they're trying to kind of do an agreement with the pharmaceuticals. The price reduction may improve access, but coverage gaps, high cost is still limit to equity. So I could not agree more on that. I was able to access to my, because you know, through my husband's insurance, he has it's like a whole, like I had to use his insurance with my insurance and all that to be able to access to it, meaning like I do have a good support system that could make me have that access to it, but not everyone has that. And a lot of people that even for diabetes, like not even for the weight loss, I've known a lot of people that for diabetes are not being approved for this medication. So that's so sad, because we all know that, you know, diabetes, uncontrolled diabetes can have really bad outcomes. So, and this is just not with pharmaceuticals like the weight loss. Also with, like, we know that mental health drugs and all that could have some challenges on being covered or not, or the provider probably wants you to take X medication, but the insurance says, no, that's too expensive. You actually need to try this first and this first. And if they don't work, then you get to the third one, which is the one that the provider wants you to do in the first place. So that's our beautiful US healthcare system. But yeah, so those are the notes that I have for now, hopefully. Yeah, thank you.